Well, good afternoon or good morning, depending on your time zone. Welcome, everybody, to our exciting co-branded webinar today between NAHDO and MedicaSoft. Today's topic will be clinical and claims data for care coordination and case management, and our speaker will be Mike O'Neill, who is the CEO of MedicaSoft. Mike is an IT industry leader with global entrepreneurial leadership embodied in decades of successful products and programs that are now the cornerstone of healthcare technology practice. He is the CEO at MedicaSoft, a senior IT advisor of HIMSS New York State chapter, and the founder and chairman of the board of the Open Source Electronic Health Record Alliance, or I'm not sure how to pronounce it, OSEHRA, overseeing solutions for both government and commercial healthcare clients. Mike has an extensive background with the U.S. Department of Veterans Affairs and previously was senior leader in private and public technology companies such as IBM, introducing new products while invigorating legacy product lines. Mike has a BS and MS in electrical engineering from Virginia Tech. Mike, let's go ahead and turn the screen over to you.
Okay, great. Thanks, Norm. Let me get screen sharing going. Okay, so yeah, thanks again, Norm. We're definitely going to talk about integrating clinical data with claims data for things like care coordination, case management. I actually, to kind of set the stage, though, I wanted to say that what I want to talk about here this afternoon is the use of clinical data on maybe a broader scale, a little bit broader scale than we sometimes think about in this context. What I mean by that is often we will think about something like a care coordinator who is getting a patient health record in order to check on a follow-up or something like that, or maybe gathering medical evidence to support analysis of a prior authorization approval, something like this. In these cases, you can almost think of it as, well, we're getting clinical data for the single task that I'm faced with here, for one patient getting one record to do one thing. That data may come directly from a provider. It may increasingly these days come from an EHR vendor. Or we may see going forward that things like national network, an e-health exchange, Commonwealth Care Quality, or as things like TEFCA evolve, other networks may be available for me to say, I am looking for a medical record for this patient, Mike O'Neill, and I can get that data and take care of my my activity. As we do more and more of this, obviously it would be better, it seems, to be able to aggregate clinical data. If we think about it in the way that we aggregate claims data, whether it's an all-payer claims database or a data warehouse or something like this, we are not going out and seeking claims data on an individual basis each time we want to do a transaction. We construct a database or a data warehouse. We decide how we're going to receive data from which sources and take care of policy type of rules and so forth. And then we have a technology solution that allows us to bring that data together and then make use of it. So in that world, what if we wanted to introduce clinical data in the same way? Maybe before I get too far ahead of myself here, it's good to just think for a moment about the use cases that we're talking about where clinical data is useful. Care coordination and case management, which we will talk about here as we go through the discussion. Clinical data can help us, or sometimes is the only way that we can do things like identify gaps in a patient's care, identify screenings that they should be having or immunizations or follow-up from treatment that they've received. Sometimes what we're interested in doing is monitoring a patient with a chronic condition to see how their outcomes are changing over time and what are the care interventions that we want to take throughout that evolution. Or sometimes it's to look for patients that, as a care coordinator, I need to do some outreach to because they're in a high-risk population. All of these things we may be able to do partially with claims data, but we really can't do completely until we have insight into the details of the patient's record and health status, which requires clinical data. Prior authorization, maybe some of us may already be kind of familiar with this, where we're looking for specific data, information, even evidence from a patient's treatment to show the necessity, the medical necessity of a procedure or a medication in order to authorize the treatment and for insurance coverage for prior authorization. Actually, I've organized the list here so that on the left side, these are things that are generally treatment-like, actually can be care delivery and care coordination, or looking at a patient's healthcare treatment. On the right side, these are things that are generally analytics-based or population health-based. The calculation of quality measures, for example, whether it's standards like HEDIS or quality measures that you as an organization may put in place that are custom for the things you need to monitor. Again, claims data is often used for a number of those metrics, but the more we need to look into the bearing on outcomes, the more we need to add clinical data to the data set that we're looking at. In terms of population health, by the way, obviously on the slide, I didn't try to make an exhaustive list here. It's more an illustrative list. So one of the things that we may do in the care coordination world is look at trends in outcomes across our member population so that we can design programs that may better meet different cohorts of patients. To do that, just to look at how outcomes are trending, again, requires us to have access to clinical data on patients. There's a whole range of things that are done in terms of value-based payments, but one example that many of you may have some familiarity with is as you are delivering value-based care, there's typically an assessment of provider performance. Are the things that we're doing to deliver care improving outcomes, and what is the associated efficiency and cost? To do those things, again, these need to be depending on clinical data. And the last thing I didn't want to go without mentioning is just from a compliance point of view, things like the CMS interoperability rule for patient access, for example. Often we think of that requiring us to payers to make available to patients the claims data that we have, but we also should make available any of the clinical data that we have about that patient. And we tend to aggregate that kind of clinical data when we're doing the calculations or the care coordination or the case management that we're talking about here. So I also thought it would be worth just talking a little bit about clinical data. Now, not that I thought that no one knows what clinical data is. We probably are all familiar with various data elements, from diagnoses to medications to immunizations, and whether we do or don't get clinical notes and so forth. But the thing that is worth mentioning is, as we look at this kind of data across our member population, we will be dealing with multiple electronic health record systems that deliver data to us in multiple formats. And even more so, just the way that they handle that data internally, how they code it, whether they code data or whether it's left as uncoded or in things like notes. All of these things vary across systems, which means as we collect and aggregate more clinical records, we will be dealing with more of that variation. It's also worth noting that even if we are talking about EHR data, EHRs themselves, providers themselves, aren't always the only source of that data. Health information exchanges can be a source of clinical data. They are aggregating data across providers in their geographical footprint every day. And as I mentioned a few moments ago, national networks, the e-health exchanges and QHINs and so forth, These are providing increasingly another method for us to get access to data. Again, each one operates slightly differently and handles the data in a little bit different way, which means from our end, when we receive this data, we're dealing with the variations that I've mentioned. I also wanted to mention that although EHR data, that clinical records in terms of what's in a patient's record in the EHR is often what we think about and often what's available for us to work with. As we go forward, there are other types of data that I think will come into play more. One is in a kind of broad category that's called social determinants of health, which you can think of as factors that affect people's health and wellness and outcomes that aren't typically the things that a doctor or nurse records in your record. It's not your blood pressure or the medication that you're taking, but these may be questions about work life, home life, food stability. They can tend towards behavioral health, these kind of things. They're most often captured through the form of questionnaires or screenings that may be done in a doctor's office, outside a doctor's office these days via mobile app. Again, from a data point of view, and what we're interested as we try to aggregate more clinical data is this type of data is going to come to us with maybe even more variation than we see with EHR data. How do we get what the questions are, what the responses are, and how do we then translate that into data that we can operate on? And the last thing I'll mention briefly, patient-generated data. Just think of data that you may have from any of your devices, whether it's in the Apple Health world or Apple Watch, and Apple Health application can help you gather data about your own healthcare status. All of that data can be made available from a technical point of view. There may be a question of whether we want it. If we're doing something like care coordination, your device may capture, let's say, your heart rate every 5 minutes. Do I really need all of that data to do an evaluation of gaps in care? Maybe not, but I may be very interested in daily blood pressure trends or something like this. Again, my point here is that we have the ability to introduce a valuable set of data, patient-reported outcomes, sometimes this is called. From a technology point of view, when we start to aggregate data, we will end up having some decisions to make about how do we handle large volumes of data, how do we filter it, how do we extract from that raw data what's useful for us. So if we think about some of the types of data and the sources and the variation that I just mentioned, what are some of the challenges that we have to figure out how to handle? The first one that needs to be thought of right up front is patient matching. What I mean is, if you think about my description of where clinical data can come from, there's sometimes, if you think about how many different healthcare providers and practices you yourself have seen over the course of your own healthcare story, the number can be pretty surprising. Each one of those hospitals or clinics or labs has a unique way to identify you. Well, I think we all hope that that's true, so that when we get a lab result, we can be confident that it's really for us. But the point is that each organization, they'll have a way to identify you. Often it's by a medical record number, MRN. And that's great. That allows them to be sure that when they're working with your records, that they've got the right person. However, that identification is not unique across any other organization. So if I take records that came from Virginia Hospital Center here in my neck of the woods and an urgent care clinic, there's no way to automatically tie with a single ID that those records are both for Mike O'Neill and the right Mike O'Neill. The way we end up doing this in the clinical world is often to use some technology, a master patient index or an MPI, which one of its core capabilities is to say, if you give me some attributes of the person, their name, their address, their date of birth, these kind of things, I will tell you which unique person I think that is. It sounds like I'm talking in very simple terms. Doing that is not so easy, but that's kind of a core function of a master patient index, is to keep a master ID for each patient, each person, and then the ability to say, for this record that I just received, which one of those master patients does it belong to? And then if I can get that, now I can link records together so that when I think of one patient, I can be confident that I have all of the various data that belongs to that patient and no data that is accidentally coming from another patient. To do this can require some investment in technology, an MPI, let's say, but also a process or an identity management strategy to deal with the fact that this kind of identity information can change over time. I guess I should say, I don't necessarily mean that your identity of yourself changes over time, but what can happen is, let's say you're at an urgent care clinic that captures your name and your address and a few facts about you, but not maybe all of your information. If you were to ask a master patient index, which master patient is this? They will make a best fit match. It may turn out over time that as they gather more information about you, they'll decide, you know what, that's actually the wrong Mike O'Neill, even though it's the same birthday. And that record will get assigned to the correct master patient. When that happens, we as users of the clinical data need to be able to track that and make sure that we always associate clinical data with the right master patient to the best knowledge that we have. Those kind of things, that's kind of what I mean in a practical sense by an identity management strategy. How do we deal with these types of situations? So patient matching, if we assume that we tackle that and we've got records linked to the correct patient, usually the next thing that we have to look into is how do we normalize or standardize the variety that I mentioned a few minutes ago. It's not just that the format, if you will, of how a hospital or an EHR sends us data can change or vary from one hospital to another. It's actually how they treat the data itself. Are they just sending me diagnoses as text information that I am supposed to read and understand? That's possible. That's kind of hard for software to digest. So usually it's coded. And which code set have they used? Is it a national standard? Is it local to their own EHR or their hospital? All of this kind of variation occurs every day across different clinical sources of data. So having some ability to standardize this data as we receive it so that when we then look to use it, we can be confident that we're interpreting the data in the way that it was intended when it was recorded in the record, and that we're not missing data. One of the things that feels like a real shame is when we go through all of the effort, we've got data that's been able to be sent to us and meets policy, and we're adhering to HIPAA and data sharing rules and all of that. But then when we run our algorithm to identify care gaps, for example, it doesn't see this data. Why? Well, it turns out it wasn't coded in the way that I expected. One of the things that really can go a long way to helping with this is to use data standards like HL7 FHIR, which I'm certain that many of you are familiar with at one level or another. There are a lot of attributes to a standard like FHIR for interoperability and how we exchange data. But one of the things that it addresses is how do we model, how do we represent data so that it's consistent, so that if I'm looking at a medication list and you're looking at a medication list, we have a common way to understand what is the meaning of all of that data. The last thing that I thought I would mention here in terms of just like what are the high level challenges when we start to aggregate clinical data so that we can use it for multiple use cases is there can be a lot of duplication. When you think about health records being sent from multiple hospitals, clinics, labs, from HIEs and so forth, often what happens is a healthcare system wants to know your medical history in some form so that they can treat you, and then they're updating it with whatever data is relevant to the treatment that they gave you. Then if you need to share that record with another, let's say another doctor, that medical history goes to them. Now they've got a copy of it. And if I'm looking to aggregate this data, I get all of those copies. Deduplication of that data, of the redundancy there, is actually, it's another thing like maybe like patient matching that conceptually it's easy. Well, I just don't want to see the duplicates. Please take those out. From a technical point of view, that can be very difficult. For example, to deduplicate something like, let's pick an allergy. When different clinicians record that you're allergic to peanuts or something like that, there can be a lot of different ways that they record it. What are you allergic to? What is the reaction, the severity? What was the onset? When did this start? Is it still current? Or is this something that happened in the past? And all of those things create a set of data that may be different from the way another doctor recorded it. Now, when I compare those two things, can I be confident that if I delete one, let's say this is a duplicate, that's clinically valid, that one of them, let's say, didn't specify a date that I can tell whether or not you still have this allergy. Something like that's pretty important. So what can happen is you can deduplicate data, but in order to make sure that we don't make an error that would affect clinical judgment, we may sometimes err on the side of caution and keep, in this case, both pieces of data. In any case, I think suffice it to say that in order to be flexible and keep the clinical validity of the data, it can be difficult, and it can mean that in the data sets that I use for the use cases that we're talking about here, I may have to account for the fact that there is going to be some some redundancy in the data that I'll have to account for. In talking about data and organization, there's just one more high-level point that I wanted to make, and that is in how the data is organized, let's say from a database point of view even. The use cases that I had listed on the side of the slide that are related to patient care, typically the most efficient organization of that data is going to be in the form of a patient record, and it's great if it's end-to-end or longitudinal. And what I mean is your application may be actually something that a case manager uses to view your health record. To do that, they're going to want to be able to look up a patient, say Mike O'Neill, and say, let me see the medical history, let me see this last encounter, and what was the diagnosis. Those type of applications work best, clearly, if the data is organized as a single patient record, much like an EHR would do. For the use cases that I described, generally as analytics or pop health or something like this, that kind of organization is probably not going to be efficient. You're not interacting one patient at a time and looking at, let's say, outcomes. You're looking to see over a whole patient population, or over let's say my member roster. Can I find evidence of these type of encounters? What is the distribution, let's say, of certain diagnoses and so forth? For this type of work, these type of use cases, some type of data warehouse or database that has a relational aspect that I can do queries over large patient populations, that's going to be the most efficient data organization. So something to keep in mind as we think about on this road that I've been through in the last few slides with clinical data. It's coming from a variety of sources with a mixed level of data quality. How do I aggregate it, make sure I know which patient is which? How do I standardize the content as much as I can? And the last thing is, as I'm storing it in my system, how do I organize it, thinking ahead to the types of use cases I have, where sometimes I want to access patient records, sometimes I want to access data sets that I can do analytics on. Okay, with kind of that in mind, what I thought we'd take a quick look at next is, to the extent that there is such a thing as a typical claims data system and a typical clinical data system, how are they different? And often, I think in these days, the systems that handle these types of data are different. Obviously, what I'm here to talk about is how do we bring this together as we have more and more need to integrate clinical and claims data. But often the current state may be something like this. There's a system that is built often around claims reimbursement or claims processing that deals with the data submission of claims files. I feel many of you probably have more expertise than I do in dealing with EDI type of X12 file formats. But in essence, you're bringing those claims files in, processing them, handling things like versions, and dealing with the fact that claims are often submitted and then additional supplemental submissions happen, bringing all that together. Typically, you're using something like a member ID to know which patient is which. So the patient matching issue is typically a little bit easier. We process all of that data and then we load it into a data warehouse, right? Because again, typically the use cases for claims data are some type of analytics or reporting or population health study. On the clinical data side, that data has all of the attributes that I described earlier. And so the technology there has to deal with parsing or processing a number of different formats. There's maybe less standardization across clinical data than claims data. We have the patient matching challenge. So often the system that I have that is ingesting processing data interfaces with a master patient index so that it can check patient IDs. We deal with mapping data from one code set to another, hopefully to arrive at a national standard to handle deduplication, all of these things, and then store that data in a clinical data repository where most often the use cases are for care delivery. So you can think of a clinical viewer as an EHR or a portal your provider may use, or a case manager or care coordinator would use to view and work with individual patient records. So this is often what we have. Claims data is handled one way, historically driven by the requirements of a claims processing, a claims reimbursement process. Clinical data, I should say, to still a large extent, I think, in the industry, I'm showing an actual system that is aggregating clinical data. But I feel that, like, more often than not today, what's there is an EHR. So if I'm a payer that's handling claims data and is looking to bring in more clinical data, the thing that I'm getting data from is an EHR from a single provider. Perhaps if I have the good fortune to work with a state or regional health information exchange, they have a system like this that's bringing together clinical data and aggregating it and taking care of some of the challenges that I mentioned here. But the point is, the more I as a payer want to add kind of that, the bottom of the slide type of clinical data processing, so that I can start combining clinical data with claims data, the more I'm driven to think about an integrated system that handles both. And so if we give a few minutes of thought to how we might do that, we might say, okay, we need to generalize the front end, let's call it a set of data services that understand, that can deal with the various formats that come up with claims data, X12 type of formats and so on, the variety of formats that happen in the clinical world coming from EHRs and SDOH providers and so forth. Handle all the capabilities. I won't run through all of them again in detail, but all is a set of services that understand what type of data it is that I'm receiving, match it to the right patients, get it to the right level of data quality, and then put it into a generalized repository, something that understands both clinical and claims data. There's one other notion here on the front end of the platform that I've shown, which is often for claims data, when we're dealing with, let's say, like an all-payer claims database, data comes in bulk at regular intervals, maybe monthly, quarterly, whatever. It's not uncommon. In fact, I would say it's increasingly common in the clinical world that you might get real-time data. If you're looking to aggregate data, you may set up a relationship with a healthcare provider or an HIE to receive a real-time feed. For example, an ADT feed, admissions, discharge, transfers, can tell a payer about events that have happened to their members. Well, it's just like it sounds. Did I have a member that was admitted to the emergency department or then admitted as an inpatient? Those types of things tend to come in real time. Those have technology implications on the set of data services that you need to be able to ingest and process that data. After we've kind of processed both clinical and claims data, it's very easy for me to draw the box on a PowerPoint slide and say, well, here, just put it in a common database. To do that, we have to make some fundamental decisions, though, about how we represent that data, how we model it. And here is where what we found at MedicaSoft is that HL7 FHIR as a standard for how you model data for storage is very flexible and pretty efficient for claims data and clinical data. It's extensible for handling things like social determinants of health data, patient-generated data. It gives us one data model, that allows us to store and then use the various types of data that we've been discussing here. There's another aspect that I'm kind of skipping over in this discussion here, which is policy and privacy. Maybe I'll just take a minute to say a couple of words here. As some of you may be thinking, as a payer organization, my ability, excuse me, to gather and use clinical data can be limited by technology reasons that we've mentioned, by just accessibility, but also by policy. I'm typically limited in what data I can use based on the use case. So to process a claim, I may have authority to use a certain set of data. To do care coordination, since it's kind of treatment, that may give me the ability, the authorization to access more data. To do things like quality measures, I have the ability to use a different set of data. The approach that's kind of implied here in this diagram, but it's worth saying it explicitly, is with the right system, with the right platform approach, you can ingest all of that data and then apply the correct policy so that when you access it, you are only given access to the data that matches your use case. Tagging the data is in HL7 FHIR terms. There's an ability to use what's called security labels to tag data so that you can say what that data is, and a policy can be applied so that you only use appropriate data for your use case. And in a similar vein, sometimes patient consent, their agreement to have their data shared for different use cases, has to be honored. And so there are ways that we can incorporate both patient consent, sensitive data, and policy to make sure that even though we've aggregated this data and we've got it kind of in common storage, we don't misuse it. It's only shared when it's appropriate and used for use cases where the purpose of use is correct. Okay, with that little side trip about security and privacy, in what I'm showing here, there's data organized in a FHIR repository that's optimized for care use. It's organized as longitudinal records. It's kind of an optimal data organization for an EHR or a provider portal, a clinical viewer, to access patient records and show, let's say, a care coordinator, here are the patients you're responsible for, and you can dive down into their individual patient records. In a general purpose data platform that would meet the needs we're talking about here for all of our use cases, we would also want that data available in probably a relational schema in an organization that's optimal for running analytics, for running queries, for doing reporting. Actually, a use case that's rapidly increasing is to organize that data for machine learning or AI, which is something we're not going to spend time on here today, other than to say, if you make the investment in a platform approach to organize data in this way, that's a whole set of applications that you can enable with some confidence that you know the provenance of the data that your AI is working with, and that you can apply the policies so that it's not shared where it's not appropriate. But in any case, we're talking more about the use cases that I mentioned up front, the calculation of quality measures, doing population health type of trend studies and so forth, get done on a data warehouse that's optimized for that kind of workload. The last diagram that I'll show you here kind of brings together, admittedly, it's kind of a very simplified picture, but what I wanted to do is bring together a couple of these concepts into a case. I know there are differences between case management, care coordination. Sometimes from a data point of view, their data needs are similar. So say case manager here, I think care coordinator could also be applied. But if we think about a person in that role, they want to do a few things. They have, first of all, they aren't responsible for every patient that's in the database. They will have, maybe it's a member roster or a patient cohort that they are responsible for looking into. So we'd like an application that presents them just the patients that they're concerned with, maybe a patient panel. Then they want to be able to access health records so they know what is the health status of my patient, what is the, let's say, the outcome of their most recent lab results and so forth. That information comes from the FHIR data repository organized as patient records. That's a very convenient way to enable a person in this role to access and work with patient records. It would be great if we also give that case manager some action-oriented information for the patients in your panel that you're concerned with. Here are the follow-ups that these patients should be getting. Here are screenings that are coming due, or even as simple as here are lab results that have come in since we last looked at this patient that are relevant to an action you asked a patient to take. Being able to drive the case manager's workflow with those kind of events comes from looking at the data in an aggregate and doing some analytics and then presenting the results, not raw data, but results in terms of actions to take, present those back to the case manager. And the other piece that I'm showing here is in terms of notifications, we can think of things like admission, discharge, transfer that I mentioned earlier. The case manager is likely to want to know for the panel of patients I'm responsible for, did anyone get discharged from an inpatient encounter or from the emergency department yesterday? Because there will be follow-up care that we'll want to track do they get and so forth. Those notifications can come directly from the clinical data. And in fact, if you are receiving real-time or near real-time feeds from providers or HIEs, though that traffic itself can generate the appropriate notification to tell the case manager an event happened for a patient that is of interest to you. Those notifications can be broader. ADT tends to be the most common, but it can be as simple as to say, for the patients you're interested in, here are the ones who received new lab results or a new diagnosis or something like that. Again, we're trying to take data and extract from it information that's actionable for the person who's in this role, and then present it to them in a useful way. And it's something that we're able to do if we can ingest the clinical data, the claims data that I mentioned, and then organize it in a kind of a standard way for use as patient records and for use as analytics. Okay, with that, I thought, I know I've talked a little bit in terms of technology and tried to strike some balance of relating data to use cases. Sometimes then when we think about, well, what's the investment or what is the action I would need to take from an IT point of view, sometimes it can be overwhelming, frankly. So I wanted to mention some practical considerations. So one of the first things that I think we want to keep in mind is don't be afraid to take an iterative approach. If you kind of wait until you have a chance to have a clean sheet of paper and make a totally new IT investment and all new systems, or you want to wait until everything's known about the types of data that I'll deal with, most often you never get there, and it can freeze you into inactivity. So taking an iterative approach is critical. When you do that, it's prudent to make some good architecture decisions. So one of the things that can really impact negatively productivity as we go down the road, and honestly, I would say something that I personally hate to see is if we make what we think is an optimal decision in the short term and put data in what ends up becoming a data silo. So if we say, well, today I need to enhance how I'm calculating quality measures. So let me get some clinical data, I'll put it in a database, I get my algorithms, I produce my quality measures. Tomorrow, I have care coordinators who are having trouble getting access to the patient records that they need. Okay, I go put in place a solution to do that. I put that data somewhere that works with their application and they can access it, and I go on. Over time, you end up with data that's not shareable, that's not consistent from standardization and normalization point of view, that hasn't solved the problem of linking together patients across your data silos, and you kind of never get out of that mode. You're never able to kind of go to the next level of efficiency. So making some choices early on things like data model, how you'll store data, how you will handle linking together data, whether you need to be fully involved in patient matching or find another solution, thinking about that up front. These are all good things. And although I said we weren't spending much time here today on things like privacy and security and policy, having in mind how you will be able to apply policies on data sharing or patient consent or what constitutes sensitive data or not, even if the requirements aren't on top of you today, it's likely that they will be. So thinking about how you would apply that as you go forward pays off if you give that thought today. And the last thing that I would say is probably not unique to the work we do with claims data or clinical data or healthcare, but prioritizing these kind of decisions and these kind of investments based on the real use cases that you have today and the use cases that you see coming tomorrow helps us make sure that that those investments get a good return. Okay, with that, I will stop here, and I imagine, Norm and Charles, that we have some time for questions.
We do. So we have one question already in the chat, and if there are others, people can just forward those along. The first question says, data silos and fragmented data obviously make it difficult to integrate information effectively. Can you advise how to approach this problem and what technology would be needed to do that? And then finally, is FHIR necessary to support that?
A good question, because I think in general, deciding on, I've tried to keep it general to say a data model, or sometimes if we're relational database people, we might think in terms of schemas, but making a decision on that can help you avoid the data silo point of view. And I say that because sometimes what happens is I think about what type of data am I going to be working with? Do I already have a schema that gives me a set of tables? Okay, let's use that, which then pushes me to store it in a certain database. When I go to my next task, those things are different and pushes me to use another database. If I had a way to say, look, I have a common data model, I will say that, I mean, in my experience and ours at MedicaSoft, we've found that FHIR does this well, but it is not the only one. So to answer the last part of the question, is FHIR necessary for this? No, I think you can use other data models or data schemas. The important thing is to try to pick something that can be consistent across your enterprise, your set of use cases. That way, you don't get pushed by how do I model, how do I represent this data, and then that dictates where it gets stored physically, and that answer is different for each use case I look at. That's very hard to break out of. Once you say, hey, I've got a common data model, doesn't really matter where I store it, as long as I've got the ability to, let's say, store it and extract it according to my data model, I'm kind of freed up from that limitation, which allows me to avoid physical data silos. The last thing I'll say, I was going to say, I don't want to sound like, I'm a HL7 FHIR salesman, but I guess honestly, I am a little bit. Even if you were to choose another data model, the things that FHIR allows you to do, one is represent a wide variety of data, but there's a link between the data model and the data sharing, the interoperability. So as I'm sure a number of you are aware, the definition of FHIR includes the definition of an API, a RESTful API, for how to access that data. If you choose another, let's say a schema that works for your system, the question of how you share it, what is the interoperability, is totally different. You have to go figure out, how do I do that? Do I export a bunch of tables and send it to somebody, or what do I do? So FHIR is not only a data model for representing data, but FHIR also gives you some thoughts on interoperability and how do I share that data.
Great, thank you for that answer. Do we have any other questions from our audience? Charles, did you have anything that you had thought about or brought up? So while we're waiting on that, I'm just going to announce, so this is being recorded, as I mentioned at the beginning, and we will make this available on our YouTube channel, and we'll publish this in our newsletter on the 15th, so that if you have any colleagues or friends that weren't able to make it today, for whatever reason, they want to go back and catch this, they can. It'll be available by the 15th for sure. Okay, Charles, do you have any other questions for Mike?
I'm not seeing any in the, I think, Mike, I would ask, are there, sorry, around here to make sure I'm seeing everything. Are there specific use cases where that you can kind of highlight where, or it's not even just necessarily use cases, but real world examples of people who are doing this type of integration and the benefit that it might be providing to various stakeholders, but especially state agencies or state health data organizations?
Mm-hmm. Yeah, so one use case that I can mention is health information exchanges, which I'm not sure how many folks are familiar with state or regional health information exchanges and their relationship with their state agencies. So, for example, a state Medicaid department that needs to get clinical data for Medicaid members. There are several cases that I can think of. In fact, one I think we can name in the state of Vermont. The Vermont HIE, which is called VITAL, is the acronym, aggregates clinical data for the state and surrounding areas for a pretty good set of the population. Vermont State Medicaid, instead of trying to go to each provider office to get records, goes to the HIE and gets from them clinical records for Medicaid members. It's one of those things that, it sounds simple. Here's the members. Can I have their records? People go in and out of any health plan, but including Medicaid. So who's a member on which day is different. Whether patients consented to share their data is something that has to be applied in Vermont. And the kind of the matching that I mentioned, knowing that data from multiple or from across organizations all belongs to the same patient. These things all have to be tracked. My whole point is, as an HIE, VITAL is dealing with these kind of issues for a multitude of reasons. They're able to deliver that value and deliver to state Medicaid the data that Medicaid needs and is entitled to, and only that data. Medicaid doesn't have to make the investment to go do all of those things. So in any case, that I know that Vermont is not the only state that does this, but it happens to be one that we're familiar with. So I can give you that as a real use case.
Great, thank you. Well, we are just at time. Mike, thank you for your time. Oh, do we have another one? Please provide more insights on the use of machine learning and claims data. I missed that one. Good time for just a short answer to that question.
Okay,
it's
sure.
an easy one.
Well, for us, for the purposes of this discussion today, but I can also say from MedicaSoft as a company, we're very much involved with how do we do all the things I talked about, bring all that data together so that it's organized so that you can use the data, clean data, accountable, knowing the provenance for machine learning. As a company, and even myself personally, we are not building the machine learning. We're kind of building the data and the platform on top of which our customers do that. So that may not be an exciting answer if you're hoping for great machine learning use cases, but that's the focus that we have.
Right. Well, fantastic. Thank you. I know there's a lot to that concept of machine learning that we're just still figuring it out. But thank you for your time, and thank you everyone for joining us today. Like I said, the recording will be available by the 15th, and we'll make sure that everybody has that link so that you can share it and get more attention to this important issue. So thank you, everyone. We'll see you all again soon.